Hi, this is the fourth in a series of discussions I'd like to have about death and dying in America, and this one's going to focus on cardiopulmonary resuscitation, or CPR. It is widely believed that CPR is tremendously effective, because of television and whatnot. But I would like to give some statistics I got from the Center for Disease Control, the CDC's website, regarding studies done between 2005 and 2010. And first of all, there's many reasons for dying, and cardiopulmonary arrest is essentially you die, but you can die from many things that are not fixable by CPR. You can have a pulmonary embolus, you could have a massive stroke, you could have multi-system organ failure, you could have a respiratory arrest. There's a lot of reasons whereby CPR is not going to work. CPR generally works if you have some kind of rhythm. For example, arrhythmias such as ventricular fibrillation, where the ventricles of the heart, instead of pumping, they'll just quiver. And you don't generate a pulse at all, no blood circulates. Or pulseless ventricular tachycardia, where the ventricles, instead of obeying they're not in a normal rhythm, they're contracting all by themselves, and it's willy-nilly, and there's also no pulse there. Those kinds of events are recoverable, and bystander CPR, immediate bystander CPR, witnessed events has decent outcomes. So, for example, a witnessed cardiac, excluding all those others that are not of cardiac origin, event with bystander CPR out of a hospital has an 11.2% survival rate to hospital discharge. This increases tremendously the faster an automated external defibrillator, or AED, is applied, because a lot of these rhythms improve with electricity. They require an electrical shock. And a lot of public places are having these now. I've seen them, apparently airports, a lot of airports, movie theaters, churches, malls, and actually one of the places they tested this first was in casinos in Las Vegas. Something good has come out of Las Vegas, I'm happy to reply. And they found that when security guards were trained to do CPR, immediate CPR, and apply an AED, very, very quickly, you had a better than 50% survival rate to hospital discharge for a cardiac event. And in a casino or something like that, it's most likely to be a cardiac event. Younger people have better survival rates, and they also have better outcomes. Just because you survive to discharge does not mean that you are mentally intact. The average, without bystander CPR, the average survival rate is about 9%. And if it's unwitnessed, I want to emphasize that the longer a person has been down and it's unwitnessed, the less likely it is that there will be any kind of effect from your CPR efforts. For example, the brain starts to die within 4 to 6 minutes of no blood pumping, and brain death is absolute within 10 minutes. That comes from the American Heart Association. And so in between that 6 and 10 minute period of time, there will be some brain death occur. So you have at best 10 minutes, that would, 4 to 6 minutes to have a good outcome before you find that person. and then the quicker the AED is applied, the better your outcome will also be. Now, in casinos, sports facilities actually have the best outcomes because you have healthy people. They probably have AEDs. A lot of people who know how to do CPR, they're younger. They have like 28% survival. When you get into, for example, skilled nursing facilities where you've got older people, people over, I'm going to refer to some of my statistics, so I'm going to look at them for a second. Older people, nursing home assisted living survival is about 3.7%. Over age 80, this is kind of all comers, 4.6% survival. But the out-of-hospital cardiac arrest, if 9.6% of people survive, on average, only 6.9% of them have good mental function. So they can be comatose, they can be, all the way up to decent mental function where they can still care for themselves. So they don't necessarily come out okay. CPR now, bystander CPR involves just chest compressions because there is oxygenated blood. The person was breathing, and if you continue to circulate that oxygenated blood, then you can still provide oxygen to the brain. So your 4 to 6 minute window is now considerably longer. For example, I looked this up, the world record for a person holding their breath without having, hyperoxygenation ahead of time, sucking up straight oxygen for 30 minutes was 11 minutes. So, obviously this person practiced and they had great lung capacity and whatnot. But so their heart was continuing to pump. They were just holding their breath. They managed to survive 11 minutes. So with CPR, you can probably extend that 4 to 6 minute window to 10 minutes and then hope the AED or external defibrillator comes within that period of time. Now, as I said, in a skilled nursing facility, the survival to discharge is about 3.7%. If you're at home, it's about 7.6%. As I said, the best was in a sports facility because you're generally young and healthy, 28.9%, and in a hospital, 12.8%. And you might think a hospital should have better statistics than that, but it's because people who are in hospitals are sicker. They have many more things going wrong with them that might be just strictly of cardiac. And CPR is really only going to help cardiac conditions. If a person's dying of cancer and you perform CPR and their organs are going, then they're not going to survive no matter what you do. And as I said, the older person is, the less likely they are to survive, and the less likely they are to survive to a good outcome. Which brings me to the topic of the do not resuscitate order. Now, if a person is in a skilled nursing facility and they have a cardiac event, they have a 3% chance of surviving to discharge from a hospital. And they will be discharged in no better shape or worse shape than they were in before. So that kind of begs the question of, is it worthwhile being a full code if you live in a skilled nursing facility? Now, I think if you ask most Americans, how do you want to die? They're going to say, I want to die in my sleep. And I think a lot of us would be really disappointed to basically of being robbed of that opportunity to die in your sleep and to wake up in a hospital and be disabled afterwards. So it's something to think about, whether or not it is appropriate to be a full code. If you have an illness, let's say a chronic illness, you have metastatic cancer, and you're going to die of that metastatic cancer, it might be a blessing to die of a heart attack before you die of the pain, you experience the pain of the metastatic cancer and the lingering death. It's something I want people to think about. And if you are in a hospital and you choose to be a do not resuscitate, that does not mean do not treat. I think a lot of people are confused about that. You can say, I want to be a do not resuscitate, but I want everything else done. You know, if you happen to find me and I have no pulse and I'm not breathing, well then don't pound on my chest and intubate me. Allow me to just remain dead. But until such time, I want everything done. If I look, you know, like I need to be intubated because I'm struggling breathing, you know, you can say, go ahead and intubate me, do whatever you need to do. But if you find me and I am dead, then just let me die. As I say, you know, I mean, we all want to die in our sleep, and essentially death becomes a sleep. I will just relay that I've participated in a number of codes in a hospital, and I'm not sure anyone ever survived. And I know that one time in particular, I was participating in a code. A woman had metastatic cancer, and she was a full code, and I was doing the chest compressions, and the first thing I heard was horrible cracking sound. I had cracked all her ribs, but by law, I am required as a hospital employee to perform CPR on that person until a physician declares them dead. And I remember the crack was heard around the room, and you know, some nurses were saying, you know, this is awful, we shouldn't be doing this. And I said, we're required to do this, we have to do this. And within a few minutes, the physicians came, they heard this woman's history, and they called the code quits, because if she recovered, she was going to have all cracked ribs. I had probably punctured her heart. She was not going to have any kind of life. And CPR is fairly violent, and it's not pleasant to perform. It's not pleasant to watch. And I would like people to think about whether or not that is how you want to spend your last moments of awareness. Because if your heart is still beating and then your brain still has oxygen, you might still be aware of people pounding on your chest and breathing for you. And if that's what you really want, or if you would want to be allowed to die peacefully. The other thing is that, for example, in a hospital, a lot of the arrests are not witnessed. If a person is not being monitored with a cardiac monitor, then a lot of the arrests are not witnessed. You just walk in the room, you find the person dead. They may have been dead for 20 minutes and you don't know that, but you're still required to perform CPR. And if you have a chronic illness and it's only going to get worse, or you're already old enough that you've lived a good long life, you might consider making yourself a no code. And as I say, that does not mean we don't do everything else. We do everything else you want us to do. And it's just that if you happen to die, then we allow you to die. So I will leave you with those thoughts for today, and I hope you have a thoughtful day. Bye.